Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and I am back this afternoon. We've had two programs today. We're going to be talking about biliary breakdown, understanding gallbladder disorders. I have Dr. David Lew with me. He is with TMCOne General Surgery, and I want to share a little bit about Dr. Lew. He practices general surgery with a particular interest in minimally invasive and robotic hernia surgery. His practice includes abdominal wall hernia, gallbladder, foregut, intestinal, skin, and soft tissue, and more. Born and raised in Utah, he moved to Arizona after finishing his undergraduate education. He earned his medical degree from Midwestern University and then completed a 5-year general surgery residency in Queens, New York. From there, he completed a fellowship in minimally invasive surgery at St. John Hospital in Detroit, where he received additional advanced laparoscopic and robotic training in foregut, colon, and hernia surgeries. He is board certified by the American Board of Surgery. Welcome, Dr. Lew. How are you today?
I'm good. Thank you for that introduction.
Yeah. So I'm going to go ahead and put your PowerPoint up. We're going to learn everything we need to know about gallbladder disorders, and I'll turn it over to you.
All right. Well, thank you. Thank you for having me. Thanks for coming in to this presentation. I'm excited to talk about the gallbladder. I do a lot of different types of surgeries, but gallbladder is probably number one. It's a common issue that we see here in the United States, and especially here in the Southwest. So I'm excited to talk about the gallbladder, right? We all have one. So what does it do? What's it for? And why does it cause us some problems, right? So first off, what is the gallbladder? So it's basically this organ that's shaped like kind of like a pear. It's small. It stores and then releases bile, right? So think of it as like a little water balloon, like a small water balloon that can kind of distend, gets bigger and smaller, as it fills with bile or as it empties with bile. So what exactly is bile, right? As you can see in the picture, it's this greenish, yellowish fluid, and which is produced by the liver. And then it gets stored in the gallbladder, and then as we eat, the gallbladder squeezes, releases the bile into the intestine, which then helps to break down and digest fats and carry away the waste products. So bile is important, right? So here is the anatomy of the gallbladder, right? It's located here on the right side of your abdomen. You see the arrow? And then it sits right underneath the liver, right? And as I mentioned, the liver makes the bile, which then gets stored in the gallbladder. There's a lot of things near the gallbladder, such as the stomach here on the left side. Also, the pancreas is back there, and the intestines are back there, and there's blood vessels and bile ducts. And we'll talk about all the different relations between those parts of the body. So the gallbladder is connected to the biliary tree or the biliary tract. That's how it's all connected, right? So as I mentioned, the liver makes bile. So it then goes through these different tubes, these connections within the liver, these different bile ducts, and they all come together from the different parts of the liver to where we call this the common hepatic duct. And then that then turns into the common bile duct, and that's where it comes off from the gallbladder, right? So the liver makes bile, it goes through the bile ducts, it gets stored, goes back up here through this, what's called the cystic duct, gets stored in the gallbladder, which is the little water balloon bag. And then as we eat and the gallbladder squeezes, it goes through the bile ducts into the intestine, where it then can help digest the fats. So what are gallstones, right? We hear about gallstones. Some of you have gallstones or know that you have gallstones. I'm sure everybody knows at least someone that has gallstones. So these are basically hardened deposits of bile, and they can form in the gallbladder or in the bile ducts. They're made of different types of materials. They can be made of cholesterol or bilirubin or bile as it gets calcified and solid. Right? So what do they look like? These are real pictures of what gallstones look like. It can be this bottom right picture, that we call that sludge, like thick motor oil type of consistency, just gunk. sludge, right? So imagine how that sounds. That's exactly what it is, sludge. They can be tiny, like tiny grains of sand, or you can get bigger and bigger to different sizes. This is probably about the biggest size I've seen. I've had basically bigger than a golf ball, maybe like the size of a small avocado. I had a patient that had the gallstone filled the entire gallbladder, just stuck in there. So there are different types of gallstones depending on what they're predominantly made of. Some are made of cholesterol. We call those cholesterol stones. Pigment stones, those are the ones that are more related to bilirubin. That's a byproduct of the blood, or mixed. You can have a combination of cholesterol or bilirubin. Sometimes things get calcified in there. Right, so that's why they're the different colors. So why do we get gallstones? So it's not entirely clear, but we do know that the body does sometimes make gallstones. Right? So one thought is that the bile may contain too much cholesterol. So it is possible it could be diet related, with too much cholesterol within our diet, or too much excretion of cholesterol, not enough. The liver excretes more cholesterol than the bile can dissolve. Right? So then they crystallize and you get some stones. So other thoughts are that it contains too much bilirubin. So there are certain disorders of the body which breaks down the blood cells too much. And one of those byproducts of the red blood cells being broken down is bilirubin. So you may see this in cirrhosis. Sometimes there can be certain biliary tract infections, or infections of the gallbladder bile tract, and other things can also contribute to that. So it's also possible that gallstones can form if the gallbladder is not functioning correctly. So if the gallbladder is not squeezing and the bile is just sitting in that water balloon, it just sits there. And if the bile is not moving, we call that bile stasis. That can form into stones. It can crystallize and form into stones. Right. So gallstones are very common. Probably estimated to be about 10 to 20% of the population, or of adults. Probably greater than 20 million adults in the United States have gallstones. So what are some of the risk factors for developing gallstones? Well, we tend to see them more in women, twice as much. It's more likely in women to develop gallstones. But men can certainly develop gallstones as well. We tend to see gallstones form in women of childbearing age, so that age of 20 to 50. The more fertile, or the more pregnancies, that sort of thing, also increases the risk of developing gallstones. With men, this tends to be the older population, so even greater than 60, but certainly younger men, younger individuals can also get gallstones. So some other risk factors include being overweight or obese. This may be diet related, as we talked about with cholesterol, or from other reasons. Also, rapid weight loss can cause gallstones. So patients that have lost a huge amount of weight in a quick period of time, that predisposes patients to develop gallstones. There's probably a genetic and ethnicity component as well, as we do see gallstones in higher percentages in the Native American population, and also in Hispanics. And so we also see quite a bit of gallstones here in the Southwest. So possibly being sedentary, pregnancy, as I mentioned, oftentimes gallstones can form in pregnancies. High-fat diet, high cholesterol diet. Diabetes, as we know, contributes to a lot of different diseases and issues. So certainly that can contribute. As I mentioned before, certain blood disorders such as sickle cell anemia or leukemia that affects the blood can cause gallstones. So hormones, increased levels of estrogen can increase cholesterol levels, and progesterone also slows the gallbladder from emptying. So that may be a reason why we see gallstones more higher in the female population, and also in pregnant ladies, but also in obese individuals, right? Fat increases estrogen, right? So liver disease, as we talked about before, also affects having gallstones. So what happens when you have gallstones? Well, some patients are completely asymptomatic, meaning they have no symptoms. So maybe of those 10 to 20% adults in the United States that have gallstones, maybe 10% don't have any symptoms, or 10%, a certain percentage do or do not. So why some get some symptoms, why others don't, we can talk about a little bit why. But some of those symptoms include upper abdominal pain. That's probably the most predominant symptom, particularly here in the upper abdomen, maybe lower chest. Some patients think they're having a heart attack, and it's actually the gallbladder causing a problem. And then that can radiate to the right upper side, maybe to the back, in between the shoulder blades or the right shoulder. Some less specific symptoms could be like nausea, vomiting, bloating. Some more serious symptoms would include jaundice, right? Yellowing of the eyes or the skin. Associated with jaundice would be like itchiness. You might have some dark urine, might look like Coca-Cola. That could mean that too much bilirubin is being released into the urine and not being absorbed. Or if you're having a hard time eating, fatty foods, fevers, chills, those are other serious symptoms. So the most typical would be after eating a fatty or a greasy meal, maybe a fried meal, you might get pain in the upper abdomen, might travel to the back, might last for 30 minutes or so, and might get better. So that would be the typical, what we call biliary colic symptoms of gallbladder. So how do we diagnose gallstones? So the most common way is with an ultrasound. And some patients may have had an ultrasound for another reason and they identify gallstones. But some patients, if they're having those typical symptoms, your doctor will send you to get an ultrasound. So this is what it looks like, right? It's a bunch of black and white, right? So they have that probe on the abdomen and uses sonographic waves to look deeper into the abdomen to take a look. So in this picture here, that black part is the normal gallbladder. And the surrounding part around it, that would be normal liver. And then this would be the opening of the gallbladder. So if you go to this picture here, you can see this kind of white thing, which produces a shadow from the ultrasound. You can see that black part there. So that would indicate a gallstone. So they can be big like this, or you can see tiny small ones like this picture here, or a bunch of just sludge like we talked about, where it's just a bunch of layering gunk within the gallbladder. So the ultrasound is typically the most useful test, and oftentimes the first test that's done. CT scans is also a common test that's done. If you end up in the ER with abdominal pain, there's a good chance that the ER doctor is going to do a CT scan. And this is what a CT scan looks like. So imagine that back here, imagine laying on the table, and you go through that tube. So here's your back. Up here at the top, that's your front, that's your belly. And then on here, that's your right side. And over here is your left side. So imagine looking straight up from the feet, and there's small pictures going all the way down. So this is just one of those pictures at the level of where the gallbladder is. So here on the left side, you can see the spleen. Right, here's the kidney. Here you can see part of the pancreas. Up here's the stomach. And then here is the liver, that big organ there. And then again, you see a little bit of a balloon-shaped organ. That's the gallbladder. And then that white part here, that's the calcified stone that you can see on the CT scan. So CT scan does not always detect gallstones. If there's not too much calcium or anything that can be identified on CT scan, it doesn't always show up. So you may still have gallstones if it's not done on if you don't see it on the CT scan. That's why the ultrasound oftentimes is more useful. The CT scan is also good for seeing inflammation around the gallbladder, or to see how big it is, to see how distended it is, to see if it's causing problems. So what are the potential issues of having gallstones, right? Say your doctor found gallstones and maybe you're having some symptoms, maybe you're not. Well, what are the potential issues? So we'll talk about each of these things. So one that's common is inflammation of the gallbladder. We call that cholecystitis. So what happens is the stone gets stuck here at the opening of the gallbladder. So then you have your balloon that's stuck and you can't squeeze the bile out because the stone is stuck there. So what happens is it distends, it gets bigger. And so that distension causes inflammation of the gallbladder. The gallbladder wall gets thick and inflamed and edematous, and it distends. And that gallbladder distension can cause a lot of pain. So instead of having that 30-minute period of pain that goes away after you eat that meal, it may persist for hours and hours and hours, and that's when you go to the ER because you have pain that's not going away. Other symptoms could include some fever, but it's usually severe pain. You also have some nausea and vomiting with that. So that's cholecystitis, or inflammation of the gallbladder. So this is a picture of what a gallbladder looks like. That's a real gallbladder. That's basically a normal looking gallbladder. It's kind of bluish, greenish. It's got some blood vessels. You can see the liver behind it. And down here is the bile ducts that we talked about before. And then here is what we call the cystic duct, which connects the gallbladder to the bile ducts. So that's a mostly normal gallbladder. So here is a more inflamed gallbladder, right? It obviously looks angry. It's got some irritation. It's red, it's angry, it's swollen. So that's what it looks like when something gets stuck there and it gets all inflamed. So you can see how that could cause a lot of pain and potential issues. So gallbladder can be even worse. So this is an even worse gallbladder. That doesn't look good. You don't have to be a medical professional to look at that and say that's not normal, right? So in addition to all the inflammation, you're seeing changes of gangrene or necrosis, right? So that's a necrotic gallbladder. That could perforate, and that could, lead to infected bile within your abdomen, and that can get you real sick. So, if you leave your gallbladder too long, all that pain, that's a potential, right? So this is a higher risk of developing a gangrenous or necrotic gallbladder if you have other risk factors such as diabetes or immunosuppression or any drugs associated with that, or cancer. Stuff like that. That increases the risk of a really bad necrotic gallbladder. So some of the other things could include what we call choledocholithiasis. That is a blockage of the common bile duct. So what happens is you have stones within the gallbladder. Those stones, if they're small enough, will migrate down here into the bile duct. And then if it gets stuck in the bile duct, that can cause pain. So that's more pain here in the center of the abdomen, rather with the gallbladder, it's more on the right side. So if a gallstone gets stuck there, not only does it cause pain, but it can cause the bile to back up into the liver, and that's when you get jaundice or the yellow eyes and the itchiness. Right? Sometimes these small stones can pass into the intestine on their own. Sometimes they get stuck there. So if it gets stuck there, and then treatment is what's called an ERCP. That's an endoscopy or a scope where the gastroenterologist sticks a camera through the mouth, goes down the esophagus, into the stomach, and goes where the opening of the bile duct is and fishes out the stones through the bile duct. And that's how you get it out. But then after that's done, typically it's recommended to also remove the gallbladder because you still have a gallbladder full of stones, right? So other potential issues include pancreatitis. Pancreatitis is inflammation of the pancreas. And the two most common causes of pancreatitis, gallstones and alcohol. So those are the two things we look for in a patient that comes in with pancreatitis. Those symptoms would be severe pain in the upper abdomen that does not go away. It's pretty painful, nausea, vomiting, maybe some chills. So what happens with that is the stones also migrate out of the gallbladder into the common bile duct, and it goes past and gets stuck near where the pancreatic duct that comes from the pancreas. So the pancreas also secretes digestive juices. So when a stone gets stuck there or irritates that area, you can get inflammation of the pancreas, and that is severe pain. So that usually requires coming to the hospital, allowing the inflammation to improve, and then possibly getting that procedure that I mentioned on the previous slide, the ERCP, to remove any stones, and then eventually to get the gallbladder out, because there's a high risk of redeveloping pancreatitis even within 2 weeks. So that's why we recommend getting the gallbladder out before it causes another episode of pancreatitis, because that can be a serious illness. Another potential complication of gallstones is gallbladder cancer. So this is pretty rare. It's not very common to see gallbladder cancer, with less than 3% of the patients with gallstones developing gallbladder cancer. So the older the patient is, the larger the gallstones, the longer they've been there, that increases the risk of gallbladder cancer. But again, that's pretty rare, less common. So what do we do about gallstones? How do we treat them? Right. So diet's always a good idea, right? If you're having pain after eating greasy, fatty foods, maybe avoiding those foods might help with some of your symptoms. So you may not have pain. But gallstones can still cause pain even if you're not eating those greasy, fatty foods. If the gallstones are progressing, you might get pain every time you eat. Or I have some patients, even if they're just drinking water, the stones are stuck there so much they're having pain regardless. So that's always a good first line. Dietary changes, decreasing fat, cholesterol intake, but it does not get rid of the gallstones. So there's a medication. It's called ursodiol that, in theory, would dissolve gallstones, but in practice, it does not work very well. The gallstones have to be small, and typically we only use this for patients that are completely unable to tolerate or undergo surgery. So it's not very effective. It's hardly ever used, but that is the medication that's there. So the gold standard treatment, the main treatment that we have for gallstones is surgery, right? And so we call that a cholecystectomy. It definitively gets rid of the gallbladder along with all the stones. And unfortunately, no, you can't just take out the stones from the gallbladder, and because the gallbladder, so like I keep going back to it being like a little water balloon. Pop a water balloon, it's hard to put that back together, right? So you can't just pop the balloon and pull out the stones and sew back the balloon. You can't really do that. And it's difficult to break up the stones. It doesn't really work very well. You might think of kidney stones, or known people that have kidney stones where they've had procedures to break up those stones. That's not commonly done because it's not easily done. And if you have small stones, those can still fragment off of the gallbladder, travel through those bile ducts, and cause all those same issues that we talked about before with the pancreatitis and severe pain or getting stuck in the bile duct. So that's the problem with trying to break up gallstones either by medication or by shock waves or anything like that. So how do we do gallbladder surgery? Right, so we do this minimally invasive. We call it a laparoscopic cholecystectomy, or keyhole surgery, or robotic cholecystectomy. So the way we do that is we make tiny puncture holes, usually 4 small holes, and then we place these things. These are called ports, which allows us to insert instruments into the abdomen after we put gas within the abdomen to create a space to be able to look around and see what's going on. And we use those instruments and the camera to find the gallbladder and remove it. So that's what this picture is showing. This picture over here on the right, that's called an open cholecystectomy. That's the old-fashioned way. That's the way it was done all the time, back in the mid-1980s and before. That was the only way that was done. Laparoscopic gallbladder started taking off in the late 1980s and is the main way of treating it today. We still sometimes have to do it the old-fashioned way. If we have a really inflamed, stuck gallbladder that's been sitting there for a long time, then sometimes we can't safely do it through the small incisions. Sometimes we have to do it with the bigger incision and do it the old-fashioned way. Fortunately, we have additional technology these days. We have a robotic system that allows us to more closely manipulate the organs on the inside with better visualization. That allows us to decrease the risk of having to do a larger open incision. So this is basically how it's done. So imagine the camera looking straight in through the abdomen, through the belly button. We use these different graspers. We retract the gallbladder up and expose the special things that we need to expose to dissect it free. So the first step is to retract it, dissect all the fat that's stuck there if it's inflamed. Then we dissect the fat away, free up the gallbladder to identify the most important structures. So when we have the gallbladder, the main important structures to know are the artery. So that's right there. That's called the cystic artery. And right next to it is called the cystic duct. So we have to safely identify those structures so we don't damage the structures that are deep, like the bile ducts, because that's what we need to live. We don't want to damage the liver. We don't want to damage the pancreas. So we have to dissect those things carefully. And then here we clip the artery. We clip the cystic duct where it opens up from the gallbladder, and then cut it, and then take it out, and we stick it in a bag and take it out of your body. So that's how it's done. So this is a surgical view of how it looks, right? So this is the gallbladder. And so this is after the artery's been dissected, and this is the cystic duct, and this is where it's attached to the liver. And so then here's the other view of it. So we have to make sure we can see all the important structures so we don't injure anything deeper, like the bile duct or the intestine down here or the liver back there. So once that's all cleared up, You clip these off, cut it, take it out, dissect it free from the liver, stick it in the bag, and take it out. Okay, so besides gallstones, what are some potential issues with the gallbladder? One is gallbladder polyps. Now, you hear about polyps all the time. So these are little growths that stick out from the lining of anywhere in the abdomen or in the body, right? You're probably most familiar with colon polyps with colonoscopies. Well, the gallbladder can also develop polyps. So this is the way it looks on an ultrasound. So it does not shadow like a stone, and it doesn't move. So when they do the ultrasound, if this thing that's inside the gallbladder moves, it's more like a stone. If it's stuck to the wall, then it's probably more of a polyp. So here's a cartoon representation here of what a polyp might look like. So most of the time, these probably don't cause a lot of symptoms. A lot of times we see gallbladder polyps because your doctor ordered an ultrasound for some other reason, and they just happen to see gallbladder polyps. But sometimes you can have symptoms. Some of these symptoms may be similar to the symptoms we already talked about. Upper abdominal pain, right upper quadrant pain, especially after eating. And that's because polyps may stick up against the opening of the gallbladder, or these polyps actually might be cholesterol stones that have the appearance of polyps on ultrasound. Some polyps can have the potential to turn into cancer. However, that is fairly rare. 95% of polyps are not cancer, they're benign. So what do you do about a gallbladder polyp when the doctor says, hey, we found a polyp? What do we do? So if they're small, less than a centimeter, so that's about like this. If they're small and they're not growing and it's not causing any problems, it's reasonable to just leave it alone if you want. Generally, the recommendation is to repeat an ultrasound after 6 months and maybe annually after a year to ensure that it's not growing, to make sure it's still small. If the polyp's causing symptoms, it's reasonable to just take out the gallbladder because it's likely impossible that your symptoms will get better. Because if that gallbladder polyp's causing you symptoms, you just take out the gallbladder. If it's bigger than a centimeter, about like that, if it gets bigger, then there's a higher chance that it could be cancer or turn into cancer. So the recommendation would be to remove it to make sure it's not cancer and to prevent it from turning into something more serious. If it's even bigger, greater than 2 centimeters, there's a much higher chance that it's cancer. So certainly that would warrant having your gallbladder removed. Or if you're observing your polyp and then the repeat ultrasound shows that it's increasing in size, then that would be a reason to take out the gallbladder to make sure it's not something more serious like cancer. Other potential issues with the gallbladder, one is called biliary dyskinesia. So this is where the gallbladder is not functioning. Oftentimes we see this with patients, they may or may not have stones. So say a patient comes in with the typical symptoms of abdominal pain in the upper abdomen, especially after eating, and your doctor does an ultrasound, they don't find any stones, but you're still having typical symptoms of gallbladder pain. And so that could mean that your gallbladder is not functioning well. So biliary dyskinesia is abnormal gallbladder function, and your symptoms are similar to what happens with gallstones. So the way that is helped to diagnose that is called a HIDA scan. That's where a tracer is injected, which is in the bile, and it shows whether or not the gallbladder fills with the tracer, and then how well the gallbladder is able to squeeze and release that bile into the intestine. If you have low gallbladder function, that could indicate biliary dyskinesia. And if you're having symptoms, it may be worthwhile to remove it because that may help your symptoms get better. Some patients have low gallbladder function but are asymptomatic. In those patients, it also is reasonable to just leave your gallbladder alone if you're not having any symptoms. So questions. I guess, before we go to the questions, we can also talk about, what surgery entails, right? And what are the potential complications and issues after the fact, right? So gallbladder surgery, if it's done, electively, meaning planned, meaning you have symptoms and you diagnose gallstones, you come see a surgeon or evaluated, and you're having a pain occasionally, but it's not severe consistent pain, then you can plan a surgery to remove your gallbladder. Most of the time that's outpatient, where you come and go home the same day. It's full anesthesia, meaning you're completely asleep, but it's general anesthesia, so that means you're fasting, and then you go home and you have someone watch you overnight. Typically, the worst pain is the first few days and slowly gets better, and by 2 to 4 weeks, most patients are feeling mostly back to normal. If you end up in the ER with a severe episode of those potential complications that I mentioned with severe inflammation, usually they'll bring you into the hospital. You'll stay a day or two. You typically try to do surgery soon thereafter, and then maybe a day or two afterwards, depending on how severe the inflammation is. And patients, usually do pretty well after gallbladder surgery. There's, of course, risks with any surgery, but many gallbladder surgeries are done. Probably over 500,000 gallbladder surgeries are done in the United States every year, just because it causes problems. So, what do you do when you don't have a gallbladder? Well, your body can live without it. Right? Your body adjusts, it adapts. So instead of being able to fill within the gallbladder, the bile just goes from the liver and is able to release directly into the intestine. So that said, sometimes early after the gallbladder removal, or if you're eating fatty, greasy meals after the gallbladder removal, the bile dumps directly into the intestine, and some patients get diarrhea. So that's the one potential side effect. For most patients, that is temporary as your body adjusts, or may require some dietary changes. In a very small percentage of patients, so it's a little bit more of a nuisance and may require some medications to help control that diarrhea. But that is the one potential side effect of not having a gallbladder. But typically, most patients do fine and live fine without it. So with that, I think we'll turn it over to questions. We'll start with the online questions and then in person.
Perfect. Thank you, Dr. Lew. You actually just answered one of the questions, and that was about the negatives of no longer having a gallbladder. So it sounds like you sort of said, without that, you may have some issues, but maybe that's not necessarily a long-term issue.
Correct. It's usually not a long-term issue, and everybody reacts a little bit differently. Some patients may have occasional bloating. If some patients still have persistent symptoms after gallbladder removal, it's possible that something else is going on, like a stomach ulcer or some other, gastrointestinal issue if they still have symptoms after the gallbladder is removed.
Okay. So another question that was related was, if you've had your gallbladder already removed years ago, can you still get gallstones?
In theory, yes. That is not often seen, but theoretically, you still have the bile duct, the biliary tree that we talked about, which connects the liver past the pancreas to the intestine. So theoretically, gallstones could develop in those locations, but that is fairly rare and less common. Sometimes you have stones that may have dropped from the gallbladder from the time, between the gallbladder surgery. There may be small stones in your bile ducts that can cause potential pain and symptoms down the road, or not. If they're small enough, you may not have any symptoms. So theoretically, you could develop gallstones, but there's no big balloon for them to be stored, so they don't cause as much problems unless they're blocking the bile duct. And that would be indicated by severe pain, fever, jaundice, etc.
Okay. Now, in absence of a gallbladder, does the ability to digest those fats and other nutrients, I know you sort of mentioned, sort of takes over right through the liver, is that correct?
Correct. Yeah. So it really doesn't affect too much the ability to digest those things, because the gallbladder, it's not secreting any special enzyme. It's just secreting what the liver is already making. And so your liver is already making bile and it's emptying into the intestine. So there's no problems digesting those things. But if you have rapid emptying of the bile into the intestine, that's when you may see some of that diarrhea. But it typically does not affect your ability to digest those things.
And I noticed you had mentioned that diabetes, people who have diabetes are usually more affected, or that can be a symptom, right, of somebody with some sort of gallbladder disease. Is that right? As far as we're in the middle of diabetes month, and so diabetes is a risk factor then. Is that right?
Yes, yeah, certainly diabetes increases your risk of developing gallstones, and just a higher chance that it can cause your gallbladder to act up, right? You have a degree of immunosuppression, the gallbladder is not functioning well, just a higher degree that it turns into something worse off. So I may have touched on it a little bit, patients can have gallstones but also have no symptoms. If you're not having any symptoms, it may be reasonable to just leave your gallbladder alone. I have a careful conversation with each patient that comes in with asymptomatic gallstones, meaning I look at the ultrasound, how big are they or how small are you really having those symptoms or not? If you're completely asymptomatic and want to leave it alone, that's reasonable. Is it huge? Is it likely to cause you problems in the future? Do you have those risk factors such as diabetes? If you have some of those risk factors, I may lean more towards, hey, let's get it out before it causes a problem. But there are probably a certain number of people that live with gallstones all their life and die with their gallbladder that have had no issues. But it's hard to predict exactly, who those, patients can be. But it is reasonable to, if you're having completely no symptoms, to leave it alone. If you're having symptoms, it's likely that it'll continue to act up and cause more problems. That's why the general recommendation is to leave it, once you start having symptoms.
Okay. And are there any differences in how gallbladder disorders affect men versus women, or even different age groups?
So it definitely affects women. We see it more in women versus men. They may have more severe symptoms. For whatever reason, men, the symptoms may be less periodic and more they come on suddenly, and it's just that one attack rather than just over months or years of having occasional pain. It's that one attack, and it's usually more severe pain. Or for whatever reason, men sometimes maybe we wait longer before going to get it checked out. Those tend to be worse gallbladders once we go into there to take them out because maybe it's been acting up for a long period of time and we just are neglecting it. You can see gallstones in all ages. We see gallstones in teenagers on up, but certainly kind of in that mid-range population and above, we do see it more often, but all ages we see gallstones.
I want to put up your phone number, and can you share where your office is located? Because I assume people would come in for a consult, of course, first. So if you'll give us that information.
Sure, yeah, it's on my last slide if you want to go back to the slides. Let me go back here. Yep, so I'm at TMCOne Wyatt. It's just across the parking lot from the ER. It's 2424 North Wyatt Drive, Suite 100, and the phone number's there, 520-420-3270. So yeah, I do a lot of gallbladder surgery, as mentioned before. I also do a lot of other surgeries involving the abdomen. I do a lot of hernia surgery, abdominal hernia surgery, and I predominantly aim to do most things robotic or minimally invasive with small incisions to avoid the issues that go along with having a larger cut. Hiatal hernia surgeries, colon surgeries, hemorrhoids, any lumps and bumps, soft tissue masses, stuff like that. But certainly gallbladder is, I would say that's probably the number one surgery that I do, since it's such a common issue.
And Dr. Lew, are you doing those surgeries just done at TMC, or are they at both campuses? Are they at Rincon as well, or where are you performing surgery?
So yeah, I perform surgeries here at TMC Main Hospital. I also perform surgeries at TMC Rincon Hospital. And then I do surgeries at the Rincon Surgery Center, which is next to TMC Rincon Hospital. TMC Rincon. I do my smaller surgeries at that surgery center down there. But predominantly, most of my surgeries are here at TMC Main Hospital and TMC Rincon Hospital.
Great. I want to thank you so much for being here today. I'm going to wrap it up with our online audience and turn it over to you for any questions in person. Thanks for being here. Thanks again for joining us today. We are going to be back next week on Tuesday, November 19th for navigating the intersection of diabetes and oral health. That is on Tuesday, November 19th at 10 a.m. We hope to see you back for that program as well. Please feel free to give us a call in the office at 520-324-1960 if you would like to register for that class. We'll see you soon. Thank you.